Thanks everybody for being here. Thank you, Nigel, for being with us again, talking about a different subject today, not Perthes. So we have received many questions related to Perthes, and mainly related to Perthes in adulthood and the consequences of Perthes when you have it childhood. And obviously, Nigel, we welcome you as an expert on this topic, and basically we would like to hear it from your side with regards to Perthes and what are the effects of Perthes into adulthood.
Okay, right. Well, thank you, Loredana, for inviting me. Thank you everyone for joining. So I'm Nigel Kelly. I'm a children's orthopedic surgeon, but I also participate in a young adult hip service as well. So I see children and adults with Perthes disease and the sequelae of Perthes disease from childhood. So just a few comments really about Perthes disease in childhood, and then I'll talk a bit about what we can see it doing for adults as well. Perthes disease is a real mystery. We don't know exactly what causes it. We don't know exactly the best way to treat it. And it causes us lots of head scratching, really. We really don't have the answers, unfortunately, which is very frustrating when we meet a family and a child with Perthes disease. What we do know about it is an interruption of blood supply to the growing hip. We don't know why that happens. It's probably not a one-off event. It's probably multiple events where the blood supply is affected. And there are a few factors associated with it, but we don't know the exact cause. But by the time the child presents, the blood supply is actually growing back again, and the hip goes through a period of collapse and fragmentation, and then it starts to reossify or regrows. The bone reforms, and then the hip remodels throughout life. And then really the consequences happen from what happens to the hip at the end of growth and what shape the hip is. In terms of treating in childhood, quite a lot of the time we treat just by observation, physiotherapy, keeping the hip moving. And we know that if the hip is moving within the socket, it's not stiff, that's a good outcome. We also know that younger children tend to be a better outcome than older children, but not always. And the condition can present often just with a limp in a child, or sometimes with pain, sometimes thigh pain rather than hip pain. We know that the majority of children don't need surgical treatment, but sometimes we do talk about surgical treatment in childhood, and that's to try and contain the hip. That's to try and keep the ball in the socket to try and give it its best chance of regrowing. And children present with this condition from any age, from 18 months up until 14 years. Sometimes it's really quite varied, but most common is about 3 to 8 years of age is probably about the commonest stage of presentation. Tends to be boys a little bit more than girls as well. And so treatment in childhood varies between different units and different preferences, but it can be just physiotherapy. It can be examining the hip under an anesthetic to see how it moves. And it can be a surgery in the form of an operation on the thigh bone, which we call a femoral osteotomy, or an operation on the pelvis. And then later on during childhood as well, if the hip causes further problems, there are some other surgical options which we sometimes undertake if the hip is causing pain and limited movement. So that's sort of a bit of summary during childhood. Then when we get to the end of childhood, as the hip's remodeling, it depends how the hip ends up really at the end of growth. And we say for girls, that's about 14, and for boys, about 16 in terms of maturity of the hip. So if the hip undergrows, first of all, it can cause you to have a short leg on that side. And if that's very short, then sometimes during teenage years, we talk about treatment for that, which could either be a shoe raise or sometimes surgery to slow down the growth of your long leg. So that's something we may consider as well. But then when we get to adulthood, the outcome long-term really depends on the shape of your hip. And I just want to share a slide with you. Can you see that, Loredana? Yeah, that's showing up. Yeah, lovely. Okay. Yeah. So this is something we talk about. It's called the Stulberg classification. But really what we're looking at is how does your hip end up in adulthood? And the message is really, if you've got a round ball in a round socket and it's well covered, which is the picture on the left, it's probably going to do well. That's the best result we'd hope for. So a nice round hip joint in a nice round socket, so the hip's going to move smoothly, and that will give us the best chance of your hip joint lasting for as long as possible. And as we go across to the right, you can see the hips are looking worse and worse. And the worst combination really is a flat hip and a flat socket, because it's not going to move normally. the cartilage and the soft tissues around the hip will start to be affected, and we'll get pain and early arthritis. Now, the difficult thing about Perthes in adulthood is trying to predict what will happen as a child, but also there's a variety of ways that the hip can end up. So we can have quite a range of different features. So we can have, say, a round ball and a round socket. We can have a very flat ball part, where the socket might be reasonable. We can have a shallow socket and a misshapen ball part, which is number 3 there. We can have a very short neck. You can see my arrow there. It's part we call the neck of the thigh bone. So it's nice and long on here, but it's quite short here. And that means the muscles around the hip are working quite hard to keep the hip moving, and that can cause problems as well. And then we know that the cartilage, the bit inside the hip that we can't see on an X-ray, that can be affected as well. So we can have loose pieces and broken down cartilage, and all these things can lead to early arthritis. So what can we do? So really, a lot of it goes by symptoms. If you've got a hip that looks bad on an X-ray but it's not hurting you, or you can put up with it and you don't want to do anything, that's absolutely fine. But really, it depends how bad your symptoms are. If you've got this hip over here in number 5, something like that, there's probably very little we can do for that apart from a total hip replacement. And total hip replacement is a very good operation if you've got a bad stiff hip like this, but for younger folk, it does have consequences for the future. So it's something you'd want to discuss very carefully with your treating surgeon. Some of the other hips here, though, they do have other things which potentially we could try and treat without doing a hip replacement. So this goes into a field we call hip preservation surgery. And this is where we undertake surgery to try and keep your own hip joint going. And that very much depends on your age and your physical demands and your health, and the shape of your hip and the state of the cartilage. And these are potentially quite big operations to try and address some of the deformity in the hip. If there's, for example, a bumper bone on that one on number 3 there that you want to trim away, or if the socket is shallow, to do surgery on the socket to realign it, or to reshape the thigh bone. So we call these things femoral osteotomies, pelvic osteotomies, and then there are other procedures called a Gantz surgical dislocation, where we can address some of the problems resulting from the hip. So these are quite major surgeries, and that sort of surgery is normally done in fairly specialist centres, which there are a few around the country. If you do have a very bad shaped hip, then there is a chance you're going to end up with arthritis in your hip, maybe earlier than you would have done otherwise. But I always find it's quite difficult for an individual person to try and predict when that might happen. So if you're 20 and you've got a bad shaped hip, but it's not causing too much trouble, I can't really tell you exactly when that will cause arthritis, but the chances are it will cause arthritis earlier than maybe somebody else. But we're all different in that respect. And sometimes we see X-rays that look terrible, but the person himself is having very little trouble and is coping very well. So it's very, very variable. So that's just a summary really of what we sometimes see in adults with hip problems, and some of the options for treating it.
Thank you very much, Nigel. And I know that we have obviously received some questions in advance. With regards to Perthes, one of the questions that we have received was related to if Perthes is detected later in life, in adulthood, is the only option. Well, I guess looking at your presentation, it really depends on the consequences of Perthes.
Well, I mean, actually, it raises a point, actually, we didn't go to, is that sometimes we see people come into the adult hip clinic and they've got a hip which looks like they must have had Perthes disease as a child, but they didn't remember it. Okay, and their mothers and fathers didn't know anything about it, and sometimes it's just a niggle in childhood and they don't really know about it. Young children are very good at compensating for these things as well. So yes, sometimes we see this sort of undiagnosed childhood Perthes disease that comes along as an adult.
In those cases, and which is one of the questions that we have received, is it certain that they need to go and have a hip replacement, or again, it's an analysis that has to be done as to how bad?
Yeah, very, very individual, I think. I think you want to look at the individual person, their age and health, and their physical demands, what they want, and then the state of the cartilage in the hip and the shape of the hip.
And one question that we have received is related to a mother of 3 children who is wondering whether her children would have Perthes as well. Is that something that can be inherited?
It's so we don't exactly know what causes it. There are a few associations. One thing I would certainly say is if you smoke, don't smoke. So secondhand smoke, there is an association, not a cause, but an association with Perthes disease. But I think giving up smoking, particularly in front of your children, is good advice in general anyway, regardless of Perthes disease. But there may well be some familial element to it, but we don't really know for sure. And of course, there's nothing we could do about that if that's the case. But by and large, it's not the sort of thing we see running in families, not like DDH or even, I suppose, clubfoot to some degree.
And with management of pain in Perthes, what would usually be the normal pathway if hip replacement is not an option or is probably too early? What would be the pathway in order to control pain?
So with any hip condition we're dealing with in adults, we start off very simple. Is improving your general health and lifestyle. So stop smoking again, because that's bad for joints as well as other things. Maintain physical activity, keep your weight down, keep healthy, keep your muscles strong. And then you then get into things like modifying your activity, so finding out what you can do and avoiding things you can't do. Particularly for the hip, people might find walking long distances and running, for example, may be painful, but swimming or riding a bike or doing home gym work, whatever, that can be something they can do. And that's very good just for keeping the joints supple and keeping the muscles strong. If the leg is short, you can potentially look at a shoe raise, because if the hip is not a good shape and the leg is short, that's a bit of a double whammy. So a shoe raise or an insert inside the shoe to balance you up can help as well.
And what about leg lengthening, potentially?
Well, so if you've got a short leg from Perthes disease and you are going to have a hip replacement in the future, the surgeon will want to make your leg longer when they do the hip replacement, because if you imagine the ball part has collapsed down, so to restore your hip back to where it was, they'll lengthen your leg. So actually, in a way, having a slightly short leg if you've had Perthes disease is a benefit to when you have your hip replacement. Because what we know is that if you've had a short leg all your life and then it becomes over lengthened, people don't like it. So if it's short and we bring it back to where it should be, then people are generally more comfortable with that.
And that would be with the shoe raise.
Yeah. Yeah. So we wouldn't do leg lengthening for Perthes disease, only when you have the hip replacement, if that's what you have.
And we had a question coming in from a young adult stating that they're in quite a lot of pain and therefore would consider hip replacement at an early age, at 20.
Yep.
What are the consequences of him choosing to have a hip replacement so early?
So having hip replacement is a very good operation, first of all. It's one of the best operations that we have in medicine in terms of people's satisfaction. So it's a good operation, but there are risks. So there are risks of any operation. So there are short-term risks like complications during surgery, immediately after surgery. For hip replacement, particularly infection is the one thing we worry about. It is quite rare, but if it does happen and the artificial hip gets infected, that leads to problems and often leads to further surgery. Hip replacement is not as good as your normal hip that you have if you're a young adult, but it's better than a bad hip. It can dislocate as well, so you have to look after it after surgery. Be careful, because if the hip dislocates and keeps on dislocating, that can cause problems and lead to further surgery. But these things are relatively uncommon. Probably the biggest thing as a young adult having hip replacement is it's going to wear out in your lifetime. And on average, we're looking sort of 15, 20 years for a hip replacement, but some may be less. So that means if you're in your 20s and you're having a hip replacement, you will need to have it done again in your lifetime, and then probably again. And the difficulty with that is that each revision operation is more complicated and may not last as long as the first one. So it does set up a chain of events. So, for example, the other end of the spectrum, if you're 17, you have a total hip replacement, the chances are you're going to die before your hip replacement needs revising, because they last a good period of time. And your demands as an older adult are less than when you're in your 20s and 30s.
And in terms of understanding, obviously, what options are available, it is quite clear that somebody that has had Perthes should understand the consequences that Perthes had on their hip. And most of the questions that we receive, it seems like a lot of adults that have had Perthes don't understand what they are. So what would be the pathway there? Is it normal to go to a GP and then from a GP?
Yeah, so I think if your hip is troubling you, all the things we mentioned before, lifestyle changes, simple painkillers, activity modification, all those things are important first line step. And it's a good idea to do those things, I think, before you go to your GP, because that's the first bit of advice you normally get. And if it's becoming more troublesome, the GP can advise you on pain relief. So simple pain relief you can get over the counter. For stronger pain relief, your GP can have a discussion with you, again, depending on your medical history and your needs. And then failing that, then the next port of call would be to refer to the orthopedic department. And as a younger adult, it's a bit more complicated, so you may then be referred to more specialist orthopedic units, or the orthopedic surgeon may refer you on to that specialist unit depending on what the situation is at the time.
And one interesting question that has come in: when does Perthes disease stop? So does it come to a point where it stops and then?
Yeah, so we know it's an event in childhood, and then the hip has to then go through a period of collapse and then remodeling and reossification, we call it. And then after that phase, certainly towards the end of growth, then the disease, if you like, the active process has stopped. It's the active disease process is the loss of blood supply, and the body then heals that afterwards. So then as an adult, you're left with the consequences of Perthes disease. So you don't have an active Perthes disease in your hip, if you like, but you have the consequences of it, which has affected the growth of your hip.
So the question is, it doesn't deteriorate in time, you're left with the consequences, or are there any?
Well, the symptoms can deteriorate because if the hip's becoming worn and arthritic, then yes, it will cause you more pain. But again, that's a consequence of the shape of the hip. But the disease doesn't come back as an adult or anything like that.
And there's a question from a parent with the child. So their question relates to how do you manage it from childhood into adulthood, and as a parent, what they can do to manage Perthes. And the question is whether they need to understand themselves where they are in terms of the stages of the disease and the outcome of it. And based on the outcome, whether they need then to decide later on what to do with the child and how to help the child long term.
So again, I'm afraid it's an it depends answer, but so you certainly need to discuss with your treating doctor and see where you are in the disease process, because that changes over time. Is it more towards thinking about what happens long term then? Is that the question? Yeah. So I mean, if you have Perthes disease in your hip, it can have long term consequences for what you do. And if the hip does grow in a shape which is not very satisfactory, then certainly, it can affect your options for the future. You might, if your hip is in a bad way, you might not want to go down the line doing a heavy manual job as a child. You might want to think about your career options around that. So, and it can have unfortunate consequences. For example, we sometimes get young people who want to join the forces or the police, and if you do have an established hip problem, that can potentially work against you. However, there are people with Perthes disease who play professional football, so it's not always doom and gloom. It just depends how it works out. Yeah.
Yes, and that person is Steps ambassador, Declan.
Yeah, great. Yeah. Right, yeah.
Professional football, yes. And in terms of the link that we have, a lot of questions related to is Perthes a consequence of hip dysplasia? Or is hip dysplasia linked to Perthes? This is a question that we are asked quite often.
Oh, okay. So when you say hip dysplasia, we mean DDH?
With DDH,
yeah. No, there's no link between the two. However, the confusion arises is that you can get a thing called avascular necrosis after treatment for DDH, which causes a problem in the blood supply to the hip and can cause a problem in the growth of the hip. So it's not that DDH causes Perthes disease, but the outcome could be similar. So, for example, if fortunately the hip had avascular necrosis after treatment for DDH, then the long-term shape of the hip could be affected, which might be similar to Perthes disease, if you like.
But
I think I recall in 16 years a couple of patients who looked like they had DDH and then looked like it was Perthes disease later rather than avascular necrosis, if you like. So they may be just unlucky and had two conditions in one person, but there's not a link between the two.
And that's an interesting question coming in from a parent that they were treated for DDH and after, when they were 2 years of age, developed Perthes. And I guess. Yeah,
could be unlucky you've had two things, but it could be that there's been a problem with the blood supply. But when we see avascular necrosis after DDH, the X-rays that we see, they look different to when we see Perthes disease.
Okay, that's a question that we get asked quite often.
Yes. Okay. Yeah.
And one last question: it's Perthes and sport. most. And I know we talked about probably swimming better, cycling better than probably running. But what about, for example, trampoline and jumping?
So I think in children early on, when they're going through the initial phases, Perthes can flare up. And if a child does too much physical activity, sometimes it flares it up and they get pain. And the problem when they get pain is that the hip gets inflamed and the child's natural reaction is to hold the hip stiff. And what we really don't want in the early phase of Perthes is to have a stiff hip. We want it to be moving. So we use the analogy of the ice cream scoops. We want the hip to be moving around there so the hip's remodeling and regrowing. If it's stiff, that's not good. So I would sometimes caution against using a trampoline because young children have no break, do they? They'll just go for it, jump up and down, and then pay for it later. So I'd certainly during the early phases, I'd offer some caution. Now it's difficult because young children, you can't stop them running around. They'll be jumping on the bed when you're not looking or whatever they're doing. But particularly things like trampolines and bouncy castles, I think they can irritate their hip. And then I'm just concerned about losing that motion. But this is really during the first sort of few months or so of the condition.
And with pain in general, a question that has come in is pain management.
In children?
In adults.
In adults. Yeah, again, this is something, it's for any painful condition. There's nothing particular to Perthes disease. It's something you'll discuss with your doctor normally. So it's over-the-counter medicines, paracetamol, ibuprofen, if you can take them. And then in terms of pain relief, there are different medicines, stronger anti-inflammatories, medicines that contain codeine and other morphine-based drugs. And then there are a few other pain management medicines such as gabapentin and pregabalin that people have as well. But that's normally a discussion you'd have with your family doctor about that.
Okay, and I think that was our last question. I can't see any others being submitted, so perfect. Thank you very much, everybody, for attending today. And for those of you that sent questions in via the email address, Nigel, thank you very much again for your time. Much appreciated. And thanks everyone else for attending. Thank you. Bye-bye, everybody.
Okay, thank you. Thank you, everybody. Thank you.
Bye.